radiology and some other things. So you'll be able to apply some of the things you're going to be learning, which is nice. When you're just learning it without being in clinic, it makes it a little harder to apply it. And it's like, gosh, why do I need to know this stuff? For the exam, there are no figures, so you don't need to stress on that. I would tell you if there is a figure that you need to know. In the oral path course, there are figures, okay? I'm not gonna say, just here's a piece of histology and what is this? I would never do that to you because it's not an easy thing to do, especially when you don't practice. And even when you practice, it's not easy too. So it takes a lot of learning to get to be able to look at a histologic specimen and know that. The thing that I think is really important as a clinician, you're going to need to be able to understand a biopsy report. So say you have a patient who you've seen and you took a biopsy and you sent it off and it comes back. What do you do with that? What do those words mean? Is there something that I should be worrying about? So for me, as a clinician, you need to be able to see something. You need to be able to know what to do next, write it down properly. And then if you're going to send off a biopsy or even refer that patient, what do I need to do in that regard, no matter what the entity is? Do you see what I'm saying? So that's why I don't think you need to be able to look at a histologic specimen. We used to have to. When we went to in dental school, actually, we spent time looking at the microscopic slides. But on boards, they will ask you questions that are more of the descriptions of what is on of a disease itself. Like an ameloblastoma, what is the histology? They might give you the histology and ask you the words of what the histology is and ask what entity would that be specifically. Okay, so again, they're not going to give you a slide and ask you what is this specific lesion. Okay, any questions about the exam? And Dr. Bork's finding out about the independent study that Dr. Boehm has on the schedule coming up. I think it's tomorrow afternoon, right? And so, or Thursday afternoon. Is that tomorrow? That is tomorrow. See, again, I'm stuck on East Coast time. Rhode Island was beautiful, a lot of fun, but again, it's hard to come back and say, okay, now I got to get back into teaching, and we have a long summer ahead of us, but it'll be fun. Okay, I promise you it'll be fun. Okay, so we're going to talk about bony neoplasms. So musculoskeletal system, there's lots of things that are both systemic and also that are more specific to the oral cavity, and some of these things will carry over again into the fall, so I'll touch base on some of them now. Just wanted to give you a sprinkling of things that we know, we see things in the oral cavity that are also systemically involved, okay? So we're going to really talk about what are those demographics that go along with the disease or a pathologic entity, and you really kind of have to get to know those and understand them. So on an exam question, I might ask you, say osteosarcoma has these specific features. I might ask have two different statements, in which the first statement is true, second statement is false, and so forth. Those kinds of questions. All the following are features you might find in this specific disease, except for. So I know you guys all hate those. So you really have to know the details of the demographics, okay? And again, then what are the treatments? What are the things that are my considerations as a dentist that I need to think about in regards to these types of entities that we'll discuss? And then when I talk about histopathology, I often want to make sure you understand why this is important. In other words, what's the behavior like? Sometimes what we see on the histology will tell us that this is why it's an important entity we really need to understand. And then ultimately, you're going to be building a differential diagnosis. When you tell a patient that you're going to biopsy something or that you see something that is unusual, they're going to want to know what it is, right? And so, and you would too if you were a patient. So you have to have in your head those top 3 things that you think this might be to be able to tell the patient. And so we always, it's somewhat going through the chances and probability based on demographics. So maybe if something's always in a child and it's an adult, well, you can throw that out, right? So that's how we start to build those differential diagnoses by what we know demographically fits a specific lesion, okay? All right, so let's just start with some benign items that we're gonna see. So this is a systemic disease, and it's a genetic inherited process, osteogenesis imperfecta. Anybody ever heard of osteogenesis imperfecta? Okay. All right, so you're going to get a little bit of overlap between Dr. Bork and myself and some of the other lecturers too. Dr. Labasani may talk about this later as well in some of her lectures. So you'll see some of these overlaps, which is good because it's redundant and you get to know those things, because these are things that this will show up on the board somewhere, okay? And so as you can see in this patient, that they actually have, you can definitely just see from their dentition that it looks unusual, right? And so just from looking at this patient's dentition, you can see that it looks like either like they grind their teeth or there's some other issue maybe with the enamel quality. Just looking at this picture, it looks unusual, not what we would expect. But in these patients, there's actually a mutation in a gene that is causing the problems that we see. So it is type 1 collagen that is the problem in these patients. So there's a mutation. And so that most likely to be autosomal dominant in its inheritance pattern. When it's autosomal recessive, they tend to have a more aggressive form, as in most entities, okay? And then you can see how their teeth look a little unusual. The quality of the enamel looks funny. And you can definitely see in this patient that the skeletal structures look a little unusual. So demographics, males equal to females. So you really, in demographics, unless it's really, really skewed to one or the other in general, I would just say, I'm not gonna ask, you know, is it female or male demographics, unless it's something I tell you specifically that you need to worry about. In this case, it's equal. Infant and young children, these are the patients, obviously, it's inherited. We're gonna see it from birth. Through their growth pattern, this type of a disease process. And then we will see in the patients what we call opalescent dentin, okay? And so the actual teeth itself look unusual because of the quality of the dentin, because if you think about how teeth are formed, collagen is a part of how teeth are formed, and so that is what we're seeing in these patients. In their dentin, there's an issue. Again, their bone as well, so you can see their skeletal structure here is unusual. 1 in 8,000 births, that's actually pretty common. I know that sounds like a lot, like a low number, but it's actually a pretty common finding. So osteogenesis imperfecta is something you might see in your practice, might have to handle as a provider, and you have to understand the different components of what these patients will present with. So when we think about collagen synthesis, there are several different pathways that are connected, right? So we have to have genes that are appropriate and able to express a protein and so forth to be able to have an actual collagen filament that then can provide what we need in the bony structure. So certain mutations in the alpha and the beta genes of collagen type 1 are where we see issues with this osteogenesis imperfecta for these patients. Some are just a deletion of a part of a gene, and some are the whole gene is missing, okay? But it all comes down to glycine. So it's pretty amazing when you think about a simple glycine specifically being an issue in an overall systemic disease that we see. Because it has to be at every third position in the collagen triple helix, when this is actually mutated or not present, that is why we will see some disruption in the presentation of the collagen in those patients. So when we think about normal bone formation, you have to have kind of this matrix of collagen laid down, and then the bone starts to form around it. So when we look at, this is collagen, this is basically cartilage. So cartilage, when you think about, it comes from collagen, right? So over time, it starts to develop into what our cartilage matrix is. And then the bone, which we see over here, is laid down within this matrix, okay? And then we get fat and marrow spaces that develop in normal bone. So in patients that have osteogenesis imperfecta, because of that collagen imperfection, we start to see unusual patterns of their bone. Okay, so they'll be irregular in the way that the bone is laid down. So that most bone has a normal pattern to it. You can see where it's laid down. You can see where it's taken up and remodeled. You know, bone is always remodeling. And so when we look at these patients, you can just see it's haphazardly arranged. So this is fibrous connective tissue in the background, right? So collagen is a part of fibrous connective tissue. These kind of strands here are collagen. And this is the bone. The darker pink is the bony areas. You can see it doesn't look very well formed. There are some hints of trabecula and the osteoblasts and osteocytes in the lacuna. So here would be a lacuna here with an osteocyte inside of it. Here's a long bone. You can see in this patient how unusual the bone looked. It looks bowed and kind of curved. And you can even see where it almost seems like it's falling apart when you look at the gross specimen. And here's what we see in the actual histologic specimen. You can see it's just not well formed. It's not thick and dense like we would expect in a long bone of our body. Again, it's very unusual in its pattern. We see similarly in teeth where they actually have shell teeth. So because the underlying dentin is not well formed, the enamel starts to break away because it can't adhere to the dentin underneath it. And they'll have really large pulp chambers too. Here's another radiograph showing how unusual that bony pattern is. We would expect it to be more dense, less spaces like we're seeing here. So you can definitely see it's kind of, when you look at the histology, there's just kind of sprinkling of calcified material, not in any distinct pattern. Even looking here, you can even see how it looks almost yellow in its color instead of that white, dense, calcified appearance. And here's what it looks like on the x-ray. So you can see what's happening with these patients. If they're going to have these bones that are very soft, then they're going to have broken bones often, right? When you think about your whole skeletal structure, it's built, especially the ribs, to protect your organs. And so then if they don't have that, you can think of like what's going to happen to that baby when it's born, if it has a really severe case, and malformed bones. Again, here's that same femur and the tibia and fibia that is actually unusual in its presentation. You can just see how it's just very unusual in its pattern. These are the calcified areas here, and then this is more fibrous connective tissue within that bone, some a little bit thicker on the outside, but then that is what we're seeing when we look at it grossly as well. So when we look at these babies, you can definitely see how the bones will kind of bend. Even in a newborn baby that actually has good bone, their bones are soft initially, right? And over time, you get more and more calcification. And so we'll start to see bowing in an unusual pattern. They almost look like they're double jointed because of that softness and the immaturity of the bone formation. The deformity of those long bones where they really, you can see, look at this arm, look at the legs, how unusual the pattern is for that baby. And again, even the ribs, look at how unusual the ribs and the spinal structure looks because of that inability to calcify and make good bone. So as you would expect, they're going to have fractures, even fractures before they're born because they don't have that good, strong, healthy bone. If you think about capillaries and other vessels, what is in that wall of a capillary, as it's being formed? There's a collagen component, right? So if collagen is not being formed, they're going to have more fragility of their actual blood vessels too. So then they're more likely to have a break in that and then a bleed. They also have osteopenia. So penia means less, so less bone as well. So there's lots of things happening with these poor kids. One of the things that we'll see clinically, and it's important to us, again, is something that we call this opalescent dentin. And here's an opal. I want to give you something to go by. So an opal has kind of a shimmery appearance with different colors in it. So when you look at the enamel and dentin underneath it, it kind of has that unusual kind of quality to it that you wouldn't expect of enamel. So when you see enamel in somebody and you know it looks really white and even thick, it's because the way the light reflects through it, right? So the light hits the enamel, and because it's such a thick piece of enamel, a good thick enamel, then they're going to have whiter teeth. If they have less enamel, it's going to have a different grayish blue appearance because of the underlying tooth structure when it reflects back at you. And that's what you're seeing. And so in these patients, they'll have blue sclera related to that collagen imperfection. They'll have a Wormian skull, which means the skull bones itself don't come together. They're very small in their structure, and so we don't get those good sutures going on to protect the brain. This is what we call the shell teeth. Let's see here. So this is basically the dentin quality is not as good as what we would expect. So the denseness of it and the ability for it to adhere to the enamel, when you think of how they interlink, that's why they call them shell teeth. There's another entity called dentinogenesis imperfecta. So you can see they're kind of similar in their name, but it's a totally different entity, but the teeth look very similar. They used to think that they were the same when a patient had the teeth-related findings, that they actually had dentinogenesis imperfecta with osteogenesis imperfecta. But they've actually looked at what is the problem with these two different diseases, and one is a different gene. So dentinogenesis imperfecta has this totally different gene that's causing the problem as opposed to the osteogenesis imperfecta. We just do see this in our patients where they get a very similar appearance to their teeth. When you think about bones not being formed well, in these patients, they'll actually have a malformed maxilla, so hypoplastic maxilla, so maybe a more retruded maxillary appearance, more mixed radiolucent and radiopaque appearance in the jaw sometimes, and then those gray teeth. So if you think about if they have really thin, or the enamel can't adhere, it's going to break more often, right? And that's why we see what appears here, like somebody who really grinds their teeth a lot. So over time, when people grind, you'll start to see that yellow of the dentin appearing within the actual crown of the tooth. And so for these patients, obviously there's going to be a totally different approach. If you think you're going to restore something like that and they don't have good dentin, well, that would pose a problem for you as a dentist, right? And knowing that and knowing their history that they have this issue is really important. There actually have been some studies looking at, well, what's happening in the dentinogenesis imperfecta patients? Why do they have that appearance? And they're thinking it's probably similar as to what we're seeing with our patients with the osteogenesis imperfecta. So in normal, this is rat teeth, and this is from a study that was done. In normal teeth, there's predentin, and predentin seems to be the area that is an issue with our dentinogenesis imperfecta patients. And so there's a DSPP gene, which is the one that's affected in dentinogenesis imperfecta. And when you look at the thickness of the predentin here, it looks a little bit different in its shape when the DSPP gene is affected. And even more so is the more severe and more mutations that we see in these patients to the point where you see just a lot of predentin. So in other words, the dentin never formed all the way to the normal dentin we would expect. It stayed as predentin. So that's why we see that really soft dentin, they lose their enamel, and then they have really, big problems going down the road with you restoring them. So we think that may be similar with our osteogenesis imperfecta patients. It's just probably a different gene that's affected in the patients related to the collagen 1 defect. Again, risk of broken bones. If they have less marrow, then they may be anemic. So you think about what does the marrow function as? What does it do for us? It helps distribute that oxygen throughout the body, right? And so we have blood coursing through there. We have blood products that are being made, and we really need all those components. That's why our body is how it is. Again, if you have patients who are wearing their teeth like this, how are we going to restore them? What are we going to do? So if you know a patient of yours has this specific disease, well, you're going to have a plan of action that goes with that to make it make the most sense and best outcome for your patient. If you had a patient that had osteogenesis imperfecta that was young and they're in your chair, you're going to want to make sure that you know what are the implications of what I can and can't do for them. I've had patients who had skeletal issues as adults, so sometimes you have to adjust to what you're going to do. You may not be able to lay them back. You may not be able to do a more serious or more complex procedure on them, depending on their disease process that they have. A lot of these patients end up with a C-section at birth to help so they don't get the fractures that might happen as they come through the birth canal. And then you'll have to know what you'd be doing. So you can see this young man had a fracture in his leg. Here you can just see with that quality of the dentin and the enamel breaking off that they're going to get caries at a higher rate. So again, you would know that, and you would help try to lessen the potential. In some of these patients, all we can do is put over dentures, try to keep the teeth that are remaining, get them to the point where they're at least stable, and then potentially over dentures. Because over dentures, when nowadays with implants, depending on their bone quality, you might be able to do that. But again, if they have poor bone quality too, you might not be able to do an implant, right? So that patient then may not be a good candidate for that. Of course, you'd find all those things out based on their genetic profile and so forth. And we'll talk a little bit about what the differences are now. There are actually 4 types of osteogenesis imperfecta. The most common one is type 1. So not all patients have that most severe case where they're having broken bones. They're not going to survive through adulthood. The most common one is type 1, and it's the mildest form, which is good. They would have blue sclera. So again, when you're looking at your patient, you're talking to them, they may not think you need to know some of these health history issues. But again, wouldn't that be nice to know? I see this patient with a really unusual look to their eye. Well, maybe they weren't honest in their health history. So you could follow up on that. This is autosomal dominant inheritance. So the main thing that we're seeing is the blue sclera and a mild form of this osteogenesis imperfecta. On the opposite side is the type 2, which is more severe. It's the most severe form, and most of these patients don't even make it through the birthing and die as a stillborn child or right after birth because they're so malformed in their bone that they actually just cannot survive. Okay, so they die at birth. You can definitely see how this young lady has a very unusual shape to her skeletal, especially the torso and legs and arms. Again, because that immaturity of the bone that's formed related to osteogenesis imperfecta. And here's that blue sclera, as you can see in this child. Again, that bone issue is what is the predominant problem for the patients. Type 3 is the second most severe form, and it's usually noticed within 6 months of birth. So in other words, they don't really see it initially. Maybe the baby, as they start to grow, they start to see things changing. They'll have some other problems like kyphoscoliosis, where they have the hump back. Okay, so other cardiopulmonary problems come up, but they were born, and then we start to find out some of the problems that are happening for them. And so you can have both types of patterns with this type 3, but again, they don't have a very long lifespan because of how severe this disease is for them. And then type 4, 50% of them will have fractures at birth. They'll have the blue sclera, and it fades with time, and it's autosomal dominant in its pattern. Again, you can definitely see the immaturity and the density of bone is very unusual. And in these patients, you can see this patient has a very unusual pattern. When you look at the comparison of enamel to dentin, it looks very unusual in its density. Okay, so we would expect a pulp chamber in here. We really don't see any in this patient here, much like dentinogenesis imperfecta. And so those are signs of something. If you started to see that throughout a patient's mouth, it should spark something, and you go, something's happening with this patient. It's probably systemic in its involvement, especially when you see it in all 4 quadrants. Anybody have any questions about that? Okay. This is from my room in Rhode Island. Beautiful view. I was like, wow, this is awesome. You'll find I love beaches, so I always have beach pictures in my presentations. Yes, Sean. Sure. We can, yes. So, right. Yeah, so every variation is going to have a different presentation. And sometimes you'll see in a patient where we think they have this severity of disease, and they might not show a specific feature. So it's variable. It doesn't always express in every single patient the same way. Okay, you'll find that in genetic type of presentations, but good question. Okay, so we're going to talk about bone dysplasias. So we're going to talk about cleidocranial dysplasia later in the musculoskeletal system. We won't talk about that today, but that is one that you definitely need to know for boards. It comes up all the time, and it's one that also has a genetic issue. So we'll talk about that again coming up in the course. Today we're going to talk about cemento-osseous dysplasia specifically, and it's something you will see, and you might see that when you go across the street in the summer to see some patients. Fibrous dysplasia, we'll talk about that in the fall, and then Paget's disease, you'll also get that as well within the musculoskeletal system. Dr. Bork will talk a little bit about that. So dysplasia itself, that word means abnormality of development. So sometimes we see the epithelium in a patient become dysplastic, so the turnover becomes abnormal. And in these patients, cemento-osseous dysplasia, the bone itself starts to be dysplastic, and we'll talk a little bit about that. So cemento-osseous dysplasia has 4 different types that we see in the oral cavity. And so there's periapical, there's localized, and there's florid, and then there's a gigantiform as well, which is an inherited presentation, and we won't talk about that today. But again, we'll talk about the other 3 because you will see them. So when you look at this radiograph, you can see a patient has a nice pulp chamber, nice PDL, and then they have these unusual radiolucencies at the apex of the teeth. And so what do you think would be the first thing we would do on this patient? Just do a root canal on them? What is our usual process to determine? Yes? See if they're abscessed or not? Yeah, so how do we determine that? We'd check vitality, right? So we check the vitality of a tooth. So you're going to learn that as you go more forward into endodontics. But we always want to know, is this lesion at the root because it's a actual infection in the root canal itself causing that tooth to be non-vital? So if a patient had a large radiolucency at the apex like that, more likely it's going to be a non-vital tooth. So the actual pulp itself is dead. So the response you would get When you stimulate it with electronic stimulation, hot and cold, is going to be nothing because it's dead, right? So there's no response that can come back from it. So in patients like these, when we see this, first off, it'd be unusual to have 3 in a row like that. But again, patients can have that. They could have an injury that caused that. They could have caries and other things. But we're always testing to know, what are we dealing with? The other thing that we can do is we can also go and feel that area. Okay, so we can palpate. We use our fingers, we use our eyes, we use all our tools. So we would feel that area. Is that actually expanding? So if they have an abscess, probably it's going to expand. Okay, so you're going to see that the bone kind of gets a little wider and fuller in that area where there's a actual cyst or some type of reaction from infection in the area. So we would feel that area. We would test it. We would have our X-rays, and we'd also know their history. Okay, and so if a patient had something like this, you could also, hopefully, you could maybe get old X-rays to compare. Is this something new? Is this something they've had for a long time? So all those pieces of the puzzle help us decide what we're going to do. Because in these patients, it's very important that we know that, because if we did something, we could actually cause them more harm. And we'll talk about that here in a second. So all the versions of cemento osseous dysplasia look exactly the same on histology. They just are different in their demographics. So this is when you have to know the demographics when we talk about it on an exam or for your patients in the dental center. So all the patients will have this immature bone. So the bone itself, you won't have consistent pattern of maturation. You won't have all the lacunae with osteocytes in there. There'll be some of that, but it'll be haphazardly arranged. Okay? And sometimes just drops of calcified material that almost look like cementum. That's why they call it cemento osseous dysplasia, because it kind of looks like cementum. So when we look at this, this is an unusual arrangement. You don't see these circles of bone laid down inside fibrous tissue as a bone is developing, okay? And when you look here, there's just multiple pieces of bone. This is the fibrous stroma, so the background that's holding it all together is a fibrous connective tissue stroma. You can kind of see where you have a little bit of that woven pattern like we would expect. Here are some osteocytes in lacuna. Again, and when it gets older, it becomes very thick in its pattern. You can see reversal lines as well, so that you'll see where it starts and stops. But it's very avascular. Again, another unusual feature that we would find in bone is vascularity. So vascularity helps it be healthy, helps it to fight off infection, helps it to lay down more bone, potentially, that is good bone with all the proper nutrients there. And then there's no inflammatory cells. So you would expect when you see a radiolucency, if you took that out, that you would have some kind of inflammation there, right, in response to what's happening. But in these patients, it's dysplastic in its turnover. So for those patients, it's actually a problem if you take it out, because they don't have vascularity there to help it heal, and they actually would start to lose more and more bone if you go and take it out. Okay, that's why we have to know what's going on with this patient. Over time, it might start out really radiolucent and with no bone in the center, and it has to have quite a bit of bone to show up, okay, as bone and recalcification. For these patients, they have aberrant turnover of bone. We don't know why. So let's start with the periapical cemento osseous dysplasia. We see this often. Again, another thing you'll see on boards, and another thing you'll see in your patients. I've had students who are off-site send me pictures and say, I think this is PCOD. Well, there's a lot of initials in oral path too, by the way, because a long word. And so do you think that's what it is? And I'm like, tell me the history of the patient, and I can give you some more clues. Again, this would be very much pathognomonic if we know all the details of the demographics. Again, this is a picture we already talked about. So this actually, we don't know why it happens, but it happens most commonly in females that are of African-American descent or black, okay? And so if you have a black female, middle-aged, with this presentation, there's no expansion, there's vital teeth, no history of trauma in that area, you don't have to do anything. Very unoften that I say you don't have to do anything. But again, you just note it, you follow it, and you make sure that nothing happens where the patient's having discomfort. So it always happens anterior mandible teeth. You see those periapical radiolucencies. Over time, they start to have more opacity. So this is an opacity here with a radiolucency around it. Here's the PDL. See the PDL of the tooth? It actually is not involved at all with this lesion, okay? If it was actual infection, you would have PDL around that radiolucency, okay? So the PDL would go, it wouldn't go right here, it would come all the way around this. So that's how you kind of know that it's separate, okay? That it's really not a tooth-related issue. It's actually a bone-related issue. Based on looking at following, where does that PDL go, okay? So if you had a patient that came in like this, you wouldn't biopsy it, because when you did that, you would actually cause them more problem, because their bone, for whatever reason, turns over unusually, and it couldn't heal. And then they would lose more bone, and then they would lose more bone. So it would be a big issue, and they can't heal. So even when we give them antibiotics and things like that, it's a problem for them. Almost like osteonecrosis of the jaw, but in a different form. So the bone just turning over unusually. Again, they could start out as radiolucencies. So just because you see a radiolucency doesn't mean that it's something else. So here, this patient has radiolucencies. You can see the PDL spaces are not involved in that. Down here, you can definitely see that there's some radiopacities beginning to form in this patient. Again, you look to see, here's our PDL, here's our PDL. We know it's something different. So they're viable, so they're vital. And usually you start to see a center of bone occurring. Not always completely in the center, but you start to see it with still that radiolucency around it. And then they're really irregular in shape. So when you have a cyst, they're often, a nice round entity that grows slowly, and the bone itself reacts to it. So you kind of see where it starts and stops. It starts to be a little unusual and not as circumscribed as we would expect, okay? But they're not going to be symptomatic. The patient's not even going to know they have it. If they have an abscess, usually they have some kind of symptoms too. So again, those are kind of clues to the hint of what's going on with the patient. Again, they become more radiopaque over time, so that's where if you were able to get x-rays from a previous dentist, you might be able to see what happened over time for the patient. Again, no treatment required for the patient. You're feeling to make sure there's no expansion. If there was expansion, we would think of central ossifying fibroma, so that would be something in your differential if there was expansion, but because there's not, it's pretty much periapical cemento-osseous dysplasia. If a patient has trauma to that area, again, they may have a harder time healing, so you have to deal with that. We don't want to go remove it unless we absolutely have to, okay? So patients who have dentures and things like that, the bone itself doesn't resorb like it would in a normal fashion, so that would be an issue for them. So we'll talk a little bit about that when we get to the localized single osseous dysplasia. Again, if you're just looking at a PA and you see that, you want to make sure you're able to see the whole mouth, because there's actually a florid cemento-osseous dysplasia where it's in all the different quadrants of the mouth. So you don't want to just get stuck on one area of the mouth. You want to be able to see the big picture. So that's where our panoramic radiographs help us a lot, because we can see the whole thing. Okay, so now we're going to talk about focal. So focal means one area. Focal is kind of like local, focal cemento-osseous dysplasia, okay? And so similar finding, except it's usually in the posterior mandible. This was anterior mandible. This is posterior mandible in this patient. You can definitely see what looks like a darker, denser area of bone here in this patient. They've had an extraction there. Maybe this is how it healed, okay? In this patient, you can definitely see something happening here in the right posterior mandible. Here's a nice third molar that's impacted. Again, we don't know why it happens. Highest percentage in females. So remember, the periapical is female blacks. In the focal, it's female whites, more so than the blacks, okay? And it's posterior mandible. So you can see where the differences are, and you can see that this is more localized to one specific region. So you're not going to see it in more than one quadrant with more than one tooth. It's actually in one specific site, okay? And so again, the histology is going to look exactly the same. The treatment's exactly the same. History is the important piece of it. They're asymptomatic, non-expansile. If you saw something like this, and it was the ossifying fibroma, which we do see in patients, it would actually expand. It would get larger. So when we see it like that, you're going to see it in the bone. You can compare left side to right side and go, that side's thicker, it's rounder in that area. That's expansion. It's causing the mandible to expand out, okay? They usually have some sort of a capsule, so you can kind of see how this darker line here, almost like a PDL, is the capsule. It's connective tissue around the bone that's growing inside of it. This one, you can't really see it as much. Again, that one's a little more foggy in its distinction between where that is and the real bone, the actual good bone is. So just depends. Over time, they get more white and more sclerotic in nature when we look at them based on the response of the surrounding mandible. Again, in an edentulous area, that area is not going to resorb. So can you see how here the rest of the mandible is resorbed over time with the loss of teeth, and this area didn't? This is the focal cemento-osseous dysplasia that was there from the get-go. So they lost their teeth. They may have had that there already, and then the denture itself, as it's sitting there and the teeth are gone, you start to get resorption, but you won't get resorption there. Now that lends itself to more likely being injured and have trauma to that area, which then the patient wouldn't be able to heal well. So knowing that ahead of time is really important. Again, no treatment's required, but you really need to understand what's going on with that patient and how you should deal with it. You wouldn't want to just remove that because that's going to cause them further problems. When we do have to go in and do something like that, we're going to put them on antibiotics. We're going to really try to help the process of healing occur. Maybe they have chlorhexidine mouth rinse to help keep down the bacteria in their mouth too. So we'll work on trying to manage it from that end if we absolutely had to remove something like that. Again, this will make a denture more unwieldy when you try to make a denture in a patient. You wouldn't want to put an implant in that area. And if that patient had the fluoride throughout their mouth, that would make it really difficult to be able to put implants in, okay? Focal like this, you wouldn't expect it to be occurring elsewhere. If it did, then it would be fluoride, okay? So if you only saw that, and that was the only thing they had, obviously you'd try to stay away from that area and put it, really understand what's going on with that patient. But you can see where you have to look ahead and think about what could be a problem for a patient like this. Again, this patient had a root canal. So was the root canal necessary? Or did they think, I see radiolucency, I'm assuming that they need a root canal, I didn't do all my tests. Make sure you do that because that's important. If you do all that and the responses you get are right on target with having a root canal and you've charted that, well, good, okay? But they could still get a focal cemento-osseous dysplasia on top of it. So they could have two things happening too. But at least you've charted that. Obviously, this patient's had restorations here, so maybe they had a restoration there that was close to the pulp, and they were able to determine that. But again, the root canal won't solve the focal cemento-osseous dysplasia. If it was infection and it has some type of sclerotic bone underneath it, it would go away with a proper root canal. In this entity, it's not going away. It's going to be there forever. Questions about that? Here you can see this patient had one that's been there for quite a while. And over time, it actually got some kind of bacteria near that area, whether it was some type of trauma in the area, they were in a denture, and now they've got infection around there, and they can't heal. And so they actually have what we call sequestration. So the body tries to ward it off, and it builds in the immune system around it, and you start to get some fibrous connective tissue and infectious material and granulomatous inflammation occurring around it. In this case, you could pluck that out of there and try and get them some antibiotics on board to help them and just really stop that process from continuing so that they don't get a fracture. Because you can see they're down here near the IA canal. That's the canal right there. You'd get a cone beam CT to really know what you're dealing with. And potentially, if you're able to just kind of pull that out without doing a lot more trauma to the area. Yes? They're benign. It's just a weird turnover of bone in that patient, okay? Much like having tori, but when it's turned over, it's avascular, so that's the biggest problem. There's no vascularity there to support it and to help fight off infection. Okay, so florid cemento-osseous dysplasia. You can see this patient in all four quadrants has that same appearance. It almost looks like cotton balls, if you will, in all the different areas. They all have radiolucencies, and they have opacities within it. And so for these patients, now you can see the demographic shifted a little bit. Again, it's still females, more likely, middle-aged, blacks, and it's in all four quadrants. Okay, so the periapical one, anterior, middle-aged black females. The focal is mandibular, posterior, females, white, okay? And then all are about middle-aged. Now, is it a hormonal imbalance, something maybe related to menopause or something? I don't know that people have really done a lot of research on it. I've not seen that. Probably because it's not something that's cancerous in nature. And for patients, if it's handled properly, it's not going to necessarily cause a problem. Now, the florid ones maybe so. but not the ones that are more, focal in that one area. So really knowing what the differences are is important. You want to know that for the exam as well. And you can even see up here in this upper area, this patient has those cotton ball down here. They're all over in this patient. So this is florid cemento-osseous dysplasia. Same exact histology, same process, just they happen to get it in all 4 areas. So they will have that irregular capsule, like this is kind of a lucency and capsule around it, and there's the opacity. Looks like one starting back here. So a very unusual appearance. Sometimes you'll see where it gets expanded, and most likely that's going to be like they got trauma in that area, an infection, and then that's what the swelling is coming from, not from the actual bony growth. And sometimes they will complain of pain, especially like that patient that had that nice little hump where their denture would sit on there. That could be painful for them, but it's mostly the tissue around it that's painful, not the actual bone, not the change in the bone, okay? And so, again, making sure that we're really looking at what are they wearing as a restoration? What are they doing in their mouth? Are they causing trauma to the area? Counseling and educating our patients are really important, and these are one of those entities we want to let them know. If you get trauma in that area, this is what could happen, and it's almost like bronze or merange if you want to, compare it to something that it could cause them a long-term problem, especially in the florid osseous dysplasia. Yes? The area, say that again? Mm-hmm. I mean, normally we would reshape the bone in the area, but it would be more harmful in some ways to them than helpful because of that avascularity of that growth. And so really knowing, getting x-rays to see like, has it progressively gotten more sclerotic and calcified in that area, or is it something that we can trim down, like some type of tori growth. And so really knowing the history would be important. You take a little bit more, you take a risk by, if it is this type of a bony replacement, that they wouldn't heal there. So you actually harm them more than help them. But for a lot of denture patients, if they have a weird shape to their bone, we will do an alveoplasty and make it a nice round shape to give us a good retention of our denture. Again, implants help in those settings, but in this patient, depending on the florid ones, you're not gonna, I don't believe you could do any kind of implant in those just because you're just not gonna have good healing, especially if they have it in all 4 quadrants. And here you can see now this patient had a cystic area here, but that's actually something completely different. He had a traumatic bone cyst, which is, we'll talk about that next semester. And this is the actual florid osseous dysplasia. You can kind of see it up here, not so much in this area, but definitely in a few quadrants you can see that that patient had something going on. So patients can have more than one thing happening. That's why we don't just take a PA, that's why we take panoramic x-rays. We really want to know what's happening throughout that whole oral cavity for the patient to be able to look at the big picture. Okay, so patients can have more than one disease happening. Again, no treatments required. You can actually see on this one, it actually has expansion. See how this side, the bone is very normal in its thickness and density, and then this side, it has an unusual pattern and it is expanding. Okay, so it just depends on the patient. Every patient's gonna be a little bit different. Most patients are not gonna feel expansion. If somebody says, hey, I have this here in this patient, what do you think? I'll say, is it expansile? Can you feel it? We're like, no. Okay, well, it's probably FCOD or PCOD or one of those. Okay, so we'll have those conversations. But again, surgery is not a good part of the next step for these patients. Okay, any questions about the osseous dysplasia? This is called the Cliff Walk in Rhode Island, a really beautiful walk. Because I don't know if anybody been to Rhode Island before? I know there's people from the East Coast here, right? Rhode Island has a lot of oceanfront area. It's kind of a weird shaped state. And so we were on the bay, and then on the other side, we walked like 3 miles, and there's the beach on the other side of the city. So it's kind of cool. And then it's daffodil time, so there's daffodils all over the place. It's beautiful. So making you all want to go to Rhode Island, huh? Yeah, okay, yeah. Clams. Clams. My son said, Mom, are you getting clams while you're there? I'm like, oh, no. He's like, you got to have clams while you're in Rhode Island. I'm like, all right. So our meeting, we actually had a clam and lobster bake. It was awesome. It was actually really good. So I did try it. I took a picture and said, I hate clams. I was like, all right, you did it. I had to have the fried kind, but yeah, because it had Had to taste better than chewy clams. But I don't like raw stuff like that. No, not good. Okay, so we're switching gears here. We were talking about a couple of benign entities. Now we're going to talk about some malignant entities. Osteosarcomas. Okay, so osteosarcomas, bone, osteosarcoma is a cancer of the bone. Okay, so knowing what that means. So osteosarcomas occur more commonly in the long bones of the body. It usually occurs in the long bones in young people. Okay, when we know what happens with bone turnover and bone addition as we grow, it makes sense why it might happen in a young person. Okay, but in the oral cavity, it's usually about 10 years older in average age. When I say 20 to 40, it could still happen, before 20, after 40. That's the common range that we see osteosarcomas, especially in the oral cavity. So extranathic sarcomas are usually in more younger people in their legs, generally in the long bones. If it happens in an adult or somebody in the oral cavity, it's usually in the mandible. That's the most common location, especially the posterior mandible. But the most common primary malignancy of bone is an osteosarcoma, and it usually happens in the femur, okay? Especially more close to where all the bone is being laid down, so right near the knee, that kind of area. So when we see these patients, we have to understand, what their disease process is and understand the prognosis for them too, for you as a dentist, what you can and can't do. Patients who have Paget's disease actually have a higher risk of having an osteosarcoma. So if they already have this disease, now they're set up potentially to have another process that's occurring, partly because of that bone that's turned over in Paget's disease is aberrant, so it can go wrong too and become an osteosarc. A patient who gets radiation, especially in the oral cavity, they're more likely to have an osteosarc later on in their life. With one treatment comes a problem and another entity occurs. Again, so you can see here, this is an osteosarcoma that's in the posterior right mandible. You can see that this PDL looks wide, okay? So whatever's happening here is impacting the PDL here. Sometimes you'll start to see bone resorption. Anytime there's a cancer, it's more likely to cause harm than like push teeth apart because it grows more rapidly. Here's one in the long bones. You can definitely see in their femur that they actually have a growth. You can kind of see it coming off. You can see it's got a little bit of bony spicules inside this soft tissue here, and it's near that kneecap too, so right where that growth plate is. Yes? Here? It's right here. So the bone looks very unusual in its pattern. Moth-eaten is how you might describe it. When bone is laid down, even though it's a cancer of the bone laying down new bone, it starts off often with resorption, and then it's laying down new bone. Okay, because it takes a lot of bone product to show up on an x-ray. So it's got to grow really fast and have a lot of bone laid down before you start to see any like spiking of bone. I'll show that in a second here. When we look at just the normal non-oral osteosarcomas, this is a nice representation of the normal age. Like I said, you can get it in the 90-year-olds. Very unusual because the most common is that 20-year-old male who gets osteosarcomas. So I know anybody know anybody that has osteosarcoma? I know 2 young people that have had it. Not relatives, just people friends, kids had it. So it is common. It is treatable in a young person, especially, if you think about it, it's the femur, they can remove that. They can put in some type of, rod in that area and let the patient heal, and they can actually be a normal, healthy individual depending on when it gets caught. So the closest to the knee is a more common area, and then it kind of, as we spread out and go, it's less common in the other areas. Again, when you look at the oral cavity compared to the rest of it, it's about a 3% comparatively to the rest of the body. Okay, so it's not as common when we see it in the oral cavity, but it happens. When we think about why does the osteosarcoma happen, we think about what the peak incidence is. It makes sense that it's something to do with that turnover, something becomes aberrant in that turnover, and it becomes an osteosarcoma. Okay, and so, like I said, those most frequent sites that we can correlate it with is that area where bone's being laid down, so that's how people have looked at it to say that's why it's happening. We don't always have an understanding of why a cancer might happen. And when you think about it, with girls, it actually happens at a little younger age, so their actual growth spurt's a little different. So that's why we've said it happens in that growth spurt time, okay? So girls are going to be a little bit younger compared to the guys. And so we just, is there any kind of genetic marker that we can look at? We're always looking for genetics and other types of ways to be able to address things like this. More and more pathology in our treatment of pathology is actually genetic focused, okay? So we can look at genes and say, can we actually treat this patient in a more custom fashion than just throw in cisplatin or some type of chemo agent at them? And so if we can find ways to actually treat them better, the outcome's even better. Because if you're just giving them that chemo, it's killing a lot of other things and causing a lot of other problems. Patients often die from the actual treatment itself, not from the disease, because it can be very debilitating. So they're constantly looking at that, but they've never been able to find a specific consistent risk factor that is associated with it. In other words, is it, you have this specific gene in you and that's why you're gonna have it. They've not been able to find one for osteosarcomas. So it's something that everybody looks at because we wanna be able to solve it if we can, or at least identify this person's at a higher risk to have it compared to the next person. And when we look at the histopathology, again, it's really unusual laying down of bone. We'll have a fibrous background, so there's fibrous connective tissue here, and this darker pink is the bone, okay? Again, you have some you have lacuna with no osteocytes or with osteocytes. We have some cartilage formation in some of these, but when we look at them, we'll see 2 nuclei in 1 lacuna. That's not usual. We'll see unusual shapes and sizes, pleomorphism. And we'll see unusual patterns of bone lay down. And so it can be very unusual in its pattern, and that's why we know that it's cancerous. So there's 3 different subtypes. So some will just be all bone in its formation. Some will have a combination of cartilage and bone. Anytime there's bone that's aberrant inside of a sarcoma, then it's an osteosarcoma. Then we categorize it by what percentage is it chondro, or is it osteo, which is the more predominant. And in some patients, the fibrous component also is cancerous. So you have bone and fibrous component also that is cancerous. So we'll look at all that, and that will help us grade what that patient has. So we'll help the surgeon understand what the prognosis is for that patient based on its behavior. So again, most have mostly all bone components, but the next step is, chondroblastic differentiation in the patient. So here you can definitely, this is cartilage. Okay, and this is actually a mix of the 2, and then this is all bone. So when we look at it histopathologically, here you have 2 lacunae and then 2 nuclei in the lacunae. So this is cartilage here, kind of has a more bluish purple appearance as opposed to the bone has a pinker appearance. These are osteoblasts here forming that bone. Then there'll be osteoclasts that'll be eating up bone too. So you'll have both occurring at the same time, just like you have normal bone, but one or the other is usually the one that's causing the problem. So osteoblasts are laying down unusual patterns. Again, very, very cellular, lots of cells in there that are unusual shape and size and color, and that's malignant in nature. So you can see here cartilage, bone, partially formed bone, very irregular in its pattern. And that's what we'll see on the radiograph too. We'll talk about that in a second. Here's actual osteosarcoma of the jaw. You can see here's a tooth, here's some good bone, and see how mushy that looks? So unusual in the pattern. Again, here's cartilage and bone that's forming and fibrous connective tissue around it. So when we look at the actual radiograph of a patient and try to understand, could this be something that's of the bad side, we're looking to see, is it destructive of teeth that are in that area? Is it laying down in an aberrant fashion? So can you see how here's the mandible, and then you have this weird bony protuberance that's unusual in its pattern. If you had a tori, it's going to be a nice, smooth shape. This actually is kind of rough in its appearance. It's not very regular. And when you look here, you can obviously see it's expanding beyond the normal confines of the mandible here. And we often see a sunburst radiopaque appearance. Here, this PDL is a little enlarged here as well. When we go to this X-ray here, you can definitely see PDLs enlarged. The bone pattern looks very rough in appearance. It's moth-eaten. We might call it moth-eaten. Here's that starburst appearance. It's very pathognomonic to say that's an osteosarcoma, okay? Again, the teeth seem to be moving around. You can see this is wide in shape. This is a mandible, kind of hard to see, but it's actually really wide in its shape, so it's expanding. Here, the bone pattern, again, is kind of moth-eaten, almost like chunks of it have fallen out, and that's how it's laid down. Here you can see it's expanding the buccal component of this area. Again, here you can see bone loss. You can see a very unusual pattern. Now you might be thinking something more of the osseous dysplasia when you first look at it, but again, you're going to look at the history, you're going to compare and see how long it's taken for it to become that change, and you'd be testing the teeth in that area, you'd be doing all kinds of things to understand that. Here you can see that this tooth was eaten away. This patient has hardly any bone here, but a little bit kind of growing off of it. Again, here's that same osteosarcoma in this area. Widened PDLs are usually a sign of something more ominous. Here, look at this here. Look how wide those are. So something's happening here. See how unusual that, like this loss of bone here, here, and just a very unusual pattern. That's a osteosarcoma. I had a patient when I was in my residency, a young kid who actually had an osteosarcoma. It looked like a growth on the side of his tooth, what we would call pyogenic granuloma, so kind of an infectious process. When we looked, the molar was pushed way up into the molar that would be coming down. It was up in the upper left, pushed way up in the sinuses. So we said, we need more radiographs. You need to go to the oral surgeon. We did a biopsy, and he had an osteosarcoma at 7 years old. Unusual, but again, we went through all the processes, and the dentist was really good to send him to a dental school where somebody might look at it differently and knew this is unusual. So again, patients can have this. You might see that in your practice. You have to be on top of it. Here you can see the teeth and how unusual that pattern is. Because it's haphazardly arranged, it's not very regular in its pattern. That's why we get that kind of sunburst, starburst pattern and very moth-eaten appearance. Here you can see this patient had something removed, and then they went ahead and put in some chains to help hold everything together, and then you can get a fracture even with those if it doesn't get better. So it's a radical surgical excision. We're going to remove as much as we can until we get to the clean bone. So think about, you have this lesion here, you're losing basically half your mandible, okay, to be able to get good clean bone. So what's it going to be downstream for that patient to eat, to have good nutrition, those kinds of things. If it metastasizes, it's usually been there a long time, and then it's going to go into the lungs most likely. So things from the mouth tend to go to the lungs first, okay? And it goes through the bloodstream to get there. Again, the most common thing is not getting it all out and having recurrence in that site. It usually doesn't metastasize. It's usually that site you didn't get a good, clean removal. 50% are surviving at 5 years, which is not a great survival, but it's better than some other cancers, okay? Here again, there are two other types that we might see. So a peripheral osteosarcoma actually has a better prognosis because it's just on the outside. So it grows within where the periosteum is on the outside of the bone. So it's not like growing through it, so you can remove it very easily, better prognosis. And then if a patient has radiation, then they can develop osteosarcoma from that change in the bone that occurs, okay? Sometimes they'll also have fibrosarcs or chondrosarcs, which are other types of cancers of mesenchymal tissue. Again, 60% of Paget's sarcomas are osteosarcs. Post-radiation, 60% of patients with radiation have sarcomas that are osteosarcs. They can also have other kinds of sarcomas. So it depends on where the radiation was aimed. This day and age, it's better than it used to be, where they can actually have targeted radiation. Again, it could take 5 to 15 years, depending on the patient and how much chemo they also had. And again, we want to verify, is it a new tumor, or is it the actual tumor that they had the radiation for? So they would do a biopsy to confirm that. So here's what that parosteal osteosarcoma looks like. See, it looks like a tori, but it's actually a cancer occurring on that outside of the bone. Again, it's very good prognosis because it's right there on the it's on the outside. It's not where all the blood and so forth is in the marrow of the bone. Here's one of those parosteal osteosarcs in the leg. So you can kind of see it's not even part of the long bone. It's on the outside. Something happened and it just started to grow. Here's that sunburst appearance. So remember that sunburst appearance. Any questions about osteosarcs? One more thing to go over. Sorry, I'm going over in time.